All right, let's begin. Hello, my name is Jackie Bruin. I'm the current president for the World Congress for Physical Therapy's HIV/AIDS, Oncology, and Hospice and Palliative Care Network, soon to be a subgroup, we're hoping. And I would like to very warmly welcome you all to the presentation today. We have the honor of having Pia Delano come here to speak to us about pediatric oncology, which is a very specialized area of PT practice, so we're just thrilled to have her. And she's from Santiago, Chile. So what I'd like to do is turn the presentation over to her, and Pia will be able to tell you a little bit about herself, and then she'll also be able to begin the presentation. So thank you for coming, and Pia, I will turn the information microphone over to you.
Okay, thank you. So welcome everybody. Today we'll be talking about physical therapy management in pediatric oncology, sequel prevention and treatment. It is a little bit of an introductory course, so if you have any questions, you can either email them to me or ask them in the final slides. My name is Pia Delano. I'm a physical therapist from Chile. I've been working with children with cancer for around 3 to 4 years. I'm currently working at Fundación Nuestros Hijos, which has an Oncology Rehabilitation Centre. We work as an outpatient clinic, and sometimes we also visit patients when they are in the hospital. So I'm going to talk to you about my experience and what I've learned and what is stated in the literature right now. So a little bit of overview. Today we will be talking about pediatric cancer epidemiology worldwide, the main types of cancer and their sequels, physical therapy assessment, including tests and treatments we use, clinical evidence, including our own experience, and we will talk about clinical cases and their intervention. We'll conclude with what's next in pediatric oncology physical therapy, and if you have any questions, you can do them then. First of all, let's discuss worldwide epidemiology. The International Incidence of Childhood Cancer Group published in 2017 the incidence in which childhood cancer occurs in the different parts of the world. As you can see, the overall rate is higher in developed countries as North America and Europe, and is smaller both in Africa and South America, which can tell us that there could be a relationship between living in a developed country and all it entails, such as fast food, medical interventions, contamination, etc. Or it could also be telling us that due to the lack of medical access, there are lower cancer registries in undeveloped countries. Now, this is the main difficulty when you want to study childhood cancer epidemiology, and why it is still not possible to find causes and prevent it. The main idea of showing this graph is that even though childhood cancer is around the 1% of all cancers, we are still talking about millions of kids worldwide that are getting it. Now on this graph, we can see the main type of cancer according to age groups. Clearly, leukemia is the main pediatric cancer, followed by central nervous systems, and we can combine all the tumors seen in the right into solid tumors, including retinoblastoma, renal tumors, hepatic tumors, lung tumors, sarcomas, germ cells, etc. Now, this is replicated by both the United Kingdom and the United States Registry. As seen before, leukemia is on top of the list, followed by CNS tumors in both cases. Now, my personal experience in Chile, we have the same situation even though we are not considered a fully developed country, with leukemia in the first place and CNS tumors in second place. It is important to notice that we did not participate in the international registry. Now, this is important because both the UK and the States have detailed registry groups and are more advanced in publishing studies regarding this population and their numbers. It is in a research done by the UK where they found out that 60% of long-term survivors had one sequel, and 30 to 40% had two or more sequels. But more importantly, 30% of those sequels were considered severe, disabling, or life-threatening. On the other hand, we have the National Institute of Health in the United States found out that survivors had a lower survival rate when compared with the regular population, and that this survival was diminishing the more the years since diagnosis. What is important of this is that most of these sequels can be prevented or treated early so that they don't become life-threatening. Now, for the main types of cancer, of childhood cancer, we have leukemia, like acute lymphoblastic leukemia and acute myeloid leukemia, solid tumors such as sarcomas, Ewing's, wounds, or organ-based, and CNS tumors, like medulloblastoma, astrocytoma, ependymoma, germ cell tumor, and the deadliest of them all, the brainstem glioma. We will see them one by one next. Now, leukemias have a 75 to 80% survival rate in developed countries, depending on where you read. There are some key factors regarding the physical therapy intervention, such as age, the stage and support of the family, and the stage of diagnosis. The figures are mainly due to treatments. For example, most of the treatment includes the use of anthracyclines, which can cause cardiac toxicity in the long term. Vincristine causes peripheral neuropathy, which is why most children refuse to walk while they are in treatment. The prolonged use of corticoids causes osteoporosis or necrosis, which can cause functional impairments for life. Now, most leukemia treatments don't include radiation, but those they do, they have radiation to the spine, which can cause necrosis of all the adjacent tissue. And all of this is double when the child has to undergo a stem cell transplant, where they receive intensive chemotherapy and are isolated in a hospital room for a long time to prevent infections. And the key factors for a physical therapy regarding solid tumors are three: location, whether it's in an organ, muscle, or a bone tissue, since it could require prosthesis or external aids; size, since the bigger the tumor, the lower the survival; and type, whether it's a sarcoma or an organ tumor, since they have different treatment approaches. Now, the main sequels of these two types are, for example, motor development delays in small children due to treatment and hospitalization, pain that could be due to the cancer or the treatment, functional impairments due to treatment or surgeries, fatigue related to cancer, which is a physical and psychological condition that can remain years after the treatment has finished, sensory impairments, as stated before, due to vincristine or other medication, malnutrition due to lack or overeating, muscular weakness, since the treatment are non-specific and can attack the muscle, especially those in the legs, and avascular necrosis, mainly in the hip and shoulder, and that can require a prosthesis or an implant. Now, for the CNS tumors, we have three key factors. Location, since tumors, for example, tumors of the posterior fossa can cause balance and coordination impairments. Those on the lobes affect specific areas. Brainstem cell tumors have no known treatment, and the neurological symptoms are progressive. And spinal cord tumors tend to be the consequence of metastasis. The treatment, which most will undergo surgery, where the main goal is to remove the whole tumor and can sometimes overlook the adjacent tissue and their functions. The radiation that can diminish the symptoms but causes a necrosis of the cerebellar tissue such next to the tumor. And the chemotherapy can cause long-term neurological and cognitive sequels. And the age. With what matters in terms of age are the motor skills previously acquired. Since it has been learned before, therefore it can be learned again. The knowledge which the child had, which comes in hand with how the child can understand the disease and the impairments acquired and their rehabilitation progress. CNS tumors are more visible than leukemia can produce one or more of the following symptoms, like gait impairments, balance difficulty, hemiparesis, lack of coordination, speech difficulty, headaches, vomits, increased intracranial pressure, and others. Most of these can resolve once the tumor is removed or with the chemostem treatment, but we have to keep an eye on them nonetheless. Now, CNS sequels can go for very mild to severe. It can affect the state of consciousness, with the child being unresponsive to stimuli, the ability to breathe independently, and the child could require a machine to do it. Paresis or plegia of one or more extremities is present in most lobe tumors and those in the posterior fossa. The movement coordination can be affected and can cause alteration in how the child walks or writes. The cranial nerves can be invaded or crushed by the tumor, generating partial paralysis, trunk paralysis, visual impairments, and difficulty in swallowing. There can be difficulties in the planification of movement, which generates balance impairments. There could be proprioceptive alterations, the presence of spasticity in one or more muscles, and of course, there could be alterations in the gait of the child, which leads to a diminished social role of the child. The St. Jude Hospital has a lifetime cohort study where they gathered the health information of more than 5,000 survivors, and as seen in the first graph, there is a more burden regarding the control group, the blue line versus the black line. However, in graph 2, you can see that this bridge is bigger when we talk about CNS tumors, which means that their sequels are more burdening than in other cancers, as seen in the lower graphs, which are about leukemia and solid tumors. Now, the physical therapy assessment of this cancer goes first by an evaluation of the physical function of the child. This can include the range of movement. Generally, you have to evaluate especially the movement of the hands and the legs, strength and sensation and proprioception. It is also important to assess the pain the child has, including how long he has had it, where it is located, and how much is it using a pain scale, which can, in young children, you can use the flat scale, or in older children, you can use the fast scale. We can also complement our evaluation with different tests for the pediatric population. Here is a list of the ones we use, which are the ones that are validated in Chile, such as the gross motor function measure, which we use for a child with brain tumor younger than 3-year-old, and it evaluates the change in gross motor function. The pediatric balance care test or BERT test, which help us to evaluate the balance measure for children with mild to moderate motor impairments. The up and go for mobility and balance, up and down the stairs for functional mobility and balance, and the 6-minute walk test for functional exercise capacity. And finally, we use the rumbar and unipedal test for static balance. We try to apply all of these when the child is referred to physical therapy, but most of the time we're unable to due to severe motor impairments or even because the child refuses to do so. However, it is a good tool to have once you want to publish something regarding physical therapy intervention. Now, there is a general idea that when the blood count of a child is low, the child should not be moved or touched. However, no exercise does not mean no physical therapy intervention. We can still play with the child and keep him entertained doing mild exercise. For example, we are an outpatient clinic, so we do not have access to the blood count. We have to refer to what the child is telling us. There are signs that the child is low on blood counts, and most of them are able to tell you about it. For example, when the child has really low blood count, he's most of the time tired, pale, and weak, and will probably be in the hospital. Now, when he is able to do light exercise, for example, most adolescents say they feel a little bit weird. They feel like they are fatigued, and they feel like they're lacking something, like they are not completely okay. And those who are okay with the blood count will be feeling well, will be feeling energized, and have a normal attitude. You always have to remind that a normal child attitude does not mean that he's going to be running up and down the stairs and through the hospital. It could mean that the child simply is feeling just okay. Now we have talked about the physical therapy treatment for some sequels, and now we're going to mention the main ones in leukemia. The neuropathy that is very common can be treated with sensory stimulation with, for example, temperature like hot and cold, different textures, and also with walking without socks and shoes on. The muscle activation is also a good tool for this type of sequel, since a child with a neuropathy, peripheral neuropathy, will probably have not been moving his feet for a long time, his feet or hands for a long time, since they feel like their hands and feet are not there, or they have pain when they move them. So we use, for example, grabbing a pen or walking, that is a functional movement, in order to restore the movement of the affected extremity. Now, the functional impairments require cardiopulmonary training with bicycles, treadmill, dancing we use a lot, and the strength and muscle mass gain can be achieved with weights. But with children, it can be difficult to use weights and keep them doing 30 reps for 10 minutes. So the best intervention is through play. We use a lot of play with childhood cancer, since it also will distract them of what's going on right now. For example, if you want to work with muscle strength of the lower extremity, you can do a dancing. You can dance with the Xbox, for example, that we have, or you can play jumping up and down, just so they can gain a little muscle mass and strength. Finally, the motor delays that are very common with young children who had leukemia can be treated with both the BOBAS or the BOFTA techniques. And as mentioned before, the main objective is to use playing as our main tool. Small children who, let's say they are 3 months old and undergo cancer treatment, will probably don't know how to play by themselves. Because let's face it, a hospital setting is not the best place to grow and to get stimulated, even though the parents can bring them a lot of choice. But the child does not learn how to play by his own, since he does not have the space to do so. Now, as solid tumors can generate impairments due to the surgery, the child will probably have to learn how to move again the area involved. This entails like functional mobility, strength, and range of motion. Also, they will require cardiovascular training due to the intensive therapy and prolonged rest they undergo. We have had children who have had scapulectomies done to them, and which means that they have to learn how to move the arm again after 14 years of moving it one way. Now they have to learn how to live with the new extremity. So it's very important that all the surgery impairments are not impairments for their daily living. So it's very important that the child can recover his whole range of motion and strength and can be independent in social settings. Now, for CNS tumors, we have three main treatment objectives. The neurological training, so the child can acquire all the motor skills and can control some of the spasticity when it is present. The balance training in all the motor levels, including sitting, crawling, it can be in prone, walking, and gait training, with the objective that it should be functional and safe. Honestly, with CNS tumors, you get the child that is not affected to the child that can move a finger due to the tumor. So we have to assess the child. Every child is unique. There's no recipe for how to treat a child with CNS tumor. Some of them can get very ataxic after the surgery. Some of them develop a lot of cranial nerves paralysis. Some of them develop severe spasticity that requires cellular interventions. We have had children who, after the surgery, did not wake up and with no clear medical reason, and children who are currently playing soccer and running without any motor difficulty. So the most important thing is always to aim for the more functional and safe gait the child could have. It could mean that the child requires a walking aid or is unable to walk, but he can move the wheelchair by himself, then that's fine. It's just always achieve what the child can do that is functional. Now, there is a lot of clinical evidence regarding the role of the physical therapy in pediatric cancer, but there is a lack of consensus on what we should be doing and how should we be assessing it. So most research go from clinical cases to this Cochrane systematic review, but the problem is that most research groups include small group of patients, and there are not many physical therapists involved in the application of this test. For example, there are a lot of 6-minute walking test assessment that is being done by nurses and not physical therapists, even though they have physical therapy intervention. And the Cochrane Library published this review last year, with the conclusions were that both in the 9-minute walk test and the up and go test, the exercise group had better cardiorespiratory fitness than the control groups. As you can see, they use the 9-minute walking test instead of the 6-minute walking test for measure, which supports the lack of consensus that we have worldwide as pediatric physical therapists. So there should be a standard for what we're looking for. I invite you all to read this review. They left a lot of research out of the review, since it did not include the 9-minute walking test or did not include control groups and others. Our own clinical experience includes around 4 different studies that we have done. There's an epidemiological study that is ongoing, but the main conclusions right now are that the average age that we receive is 9 years old, Most patients referred to physical therapy have CNS tumors, as you can see, almost 50%. And 76% had a motor sequel, and 57% had cognitive impairments. Now, cognitive impairments, even though it's not our area, that is the most unseen sequel there is. It is quite difficult to know if a child has a cognitive impairment due to the treatment or the tumor, but it is quite visible if the child cannot walk. So I want to highlight the cognitive impairments because most children will be referred to physical therapy, but they will not go to cognitive training. So we have to be the ones to be able to recognize when a child needs and has a cognitive impairment. Also, as you can see in the graph in the down right, not all the children could be assessed with all the tests. It states the up and go, the pediatric balance test, and the 6-minute walk test. Now, this is mostly because either the child is not in the condition to undergo this test, or most of the times when we receive the child, when the child is referred to physical therapy, he is still in the hospital setting. So, for example, in a hospital, it is quite difficult to apply the 6-minute walk test or the up and go due to they are still connected to an IV, or they're receiving treatment, or there is not enough space, which is what happens in our case. There is not a lot of space, so the first time we do not use the test, but we do use it when we reevaluate the children 3 months later. Now, our second study involves cancer-related fatigue and quality of life. It was concluded that the more fatigued the child is, the lower quality of life they perceive. Now, they use both the fatigue scale by Hockenberry and Hinz and the pediatric quality of life scale, which is validated in most countries, and you can receive it for free online. Now, our third study assessed the physical therapy impact in children with cancer. It recollected the data of the up and go and 6-minute walk test when they arrive at physical therapy and 3 months later. And the conclusions were that a physical therapy program significantly improves fitness in children with cancer, as the child improving both the 6-minute walk test and the up and go, as shown in the graph below. Now you can see in the graph below in the right that the X's are the 6-minute walk test. We use the formulas for the referral, for the reference results that they should have had. And the white X, the white is what was assessed at admission. The orange is what is the referral, and the blue is after 3 months of physical therapy intervention. As you can see, they significantly improve both child and adolescents in the two tests. So clearly, the chemotherapy treatment does not affect that much the performance, but it's not a limitation to do exercise and the improvement in their physical condition. Now, these are the clinical cases, our trials that I have treated, so feel free to ask questions later on. It is a summary of what was done. These trials are treated for more than a year. I think it's going on to 2 years that they have been my patients. So I know a lot of their hospital history, and you can feel free to ask what you need. Now, first we have a 9-year-old girl with leukemia. She was in active treatment. and she had Down syndrome. When she was referred to physical therapy the first time, she had severe muscle atrophy, which made her have poor balance and gait impairments. She wasn't able to walk other than to the bathroom. She wasn't able to climb up the stairs because she didn't have the strength to do so. She also had poor cardiorespiratory conditions. I mean, this was the small space that she walked to the bathroom. She was tired for the whole afternoon, and this poor cardiorespiratory condition had her moving in a wheelchair, and she was unable to play since she would tire up quickly. She also had an emotional disadaptation due to the impossibility to understand what was happening, and she had a lack of peer interaction since she had to leave her home to get the treatment. So the first steps that I did as a physical therapy treatment was to get her back to play. We started with a small play with Play-Doh, with tea party, and with dolls. When she was comfortable with me, we began gait and balance training until she was able to walk up and down the stairs. I had to trick her, so I will put the toys on top of the stairs, and she will have to go and grab them. Then we found out that she loved to dance before she got cancer, so we began to dance again. And she was able to get back to school while she finished her treatment, since she didn't have any motor impairments other than a mild cardiorespiratory difficulty, but she was back to the same girl that she was before. On the other hand, we have a 14-year-old with a posterior fossa medulloblastoma who underwent both chemo and radiation. He was in a coma for over a month after he had the surgery and all that it entailed. So when he arrived to physical therapy, he had severe balance impairments. So he had to sit with support, and he was unable to stand. He also had severe muscle atrophy that caused range of movement limitations in the ankles and fatigue. When I used to ask him to do exercise, he couldn't do more than 5 because he didn't have the muscles to do so. So we started with muscle activation in sitting and prone and sitting. We also did flexibility of the ankle muscles, so he had a shortening of the gastrocnemius. And we work on endurance and train the different motor skills from laying down to sitting, sitting to standing, standing to walking, until he was able to stand by himself and walk with a walker. He then used other walking aids until he was able to do it on his own, and we trained gait in the streets so that he would be safe. So he finally got back his independence and participation, was able to go back to his school where he goes right now, and he even goes by public transport, which we didn't thought would be possible. So that's what I mean when I said you always have to aim for the highest gait and functional activity, so the child can achieve it. Now, a quick view of palliative care, which is a part of childhood cancer. It includes 3 main strategies. Now, maintaining a good quality of life, supporting and educating the family on what's to come, and maintaining the child's ability to keep on playing. Now, I present you 2 clinical cases. The first one is a 9-year-old girl with diffuse punctured glioma who received palliative radiation. Now, she arrived to physical therapy with just a mild hemiparesia. So the treatment then involved dancing, motor skills for good coordination, and a lot of playing. Now, sadly, the symptoms progressed, and in the end, we could only help her by positioning and keeping her comfort and good quality of life. And even though she could not move in the end, we kept her involved in games until her last day. So the conclusion in this case was that we kept her playing and in comfort until it was her time to go. Now, the second case is a 1-year-old with stem cell transplant rejection who arrived with severe motor development delays and a graft versus host disease. Now, this child had been hospitalized since he was 2 months old. So when I say motor development delays, for a 1-year-old, he was only able to sit, but not by himself. He did not know how to play. And since he had this graft versus host disease, both in his hand and his feet, he refused to use them. So we had to teach him how to use his hands. Now, we work on achieving all the transitions and motor skills until he was able to walk on his own, and he was able to play as he wished. And what the mother says that keeps her calm is that he was able to play until his last day. Now, what's next in pediatric oncology? Hopefully, we can create a pediatric oncology network worldwide so that we can share and learn everything that we are doing. Currently, here in Chile, we are creating a physical therapy in pediatric cancer network. So we can all share our experience, and we can publish more evidence, and we can create a consensus on what are the best tests to assess a child who has cancer. We're lacking on research and evidence. We need more, and we need that it will hopefully be with bigger groups, but even one child experience is an experience. So if you treat just one child, register everything and publish it so that either it can be an example to others or it can be an example to yourself. We need more uncooperative physical therapists. I don't know how is the reality in other countries, but in Chile, we do not teach it on a graduate level. We even don't teach it on a postgraduate level. We are lacking on how to educate ourselves in this area. So hopefully this area can be included in the graduate programs. Undergraduate programs, it will be extremely awesome. And hopefully the physical therapist can be part of a hospital team so that we can have intensive rehab programs. We have seen that these sequels can be prevented, can be treated, but it is better to treat it when it just appeared or when it hasn't appeared than wait years and years until we can do nothing about it. So if you have any information or you want to contact me, there's my email. Feel free to email me. I tend to answer most of them in the same day, so hopefully we can create a good physical therapy network for pediatric cancer. And here are some of the references that you can go and check out. I recommend both the series statistic and the CROFNH review. They are very useful for physical therapists and who want to understand what's going on with pediatric cancer. Thank you.
Thank you, Pia. This was wonderful. This was a terrific presentation. I think you've laid some important groundwork here for how children can be evaluated using evidence-based tools that probably still need a little more work on them in this population, but also some of the case studies were very clear in different types of progress with treatment as well as the types of treatment that we can use. Do people have any questions for Pia? You can either respond through the chat line or you can respond using your microphone.
Okay.
So I'll just wait a minute and see if there's any questions that come up through the chat line. While we're waiting, I actually do have a question. Years ago when I was working on my master's degree, I was in a cardiac rehab program, and this is really about the time where I developed my interest in oncology rehab because there were mostly animal models that were looking at exercise and tumors. And there was one researcher, Roy Shepard, out of Canada. He's an exercise physiologist, and he did take a small number of children in the hospital, and I believe it was stem cell transplants that they were receiving. And he found that they could do, in the group of students that, or children who met the criteria, they were able to experience some form of training. It might have been like a 6 to 11% improvement, and it was statistically significant. But what he found in his group of students was that their metabolic level, the VO2 max that they were measuring in these kids, was 40% lower than other children of their age. And again, this was at a time where they were in treatment. So are you aware of any studies that are showing that the kids do train, but the results are much lower, so that we as PTs have to recognize that they're not going to get the same amount of training as their apparently healthy peers? And I'll let you answer my question.
Yeah. Yeah, there's a lot of information regarding transplant kids. Most of them are about muscle strength, but there are a few that talk about their cardiovascular condition. What happens with this, and my experience with this type of patients, is that they get graft versus host disease in their lungs. It is not that much visible as, for example, in their hands, but the child can even develop asthma after the stem cell transplant. But that is, what I've seen is that it's not a very huge impairment for them to do exercise. They can probably do everything that another child can, even though they have a lower capacity than their peers, but they do get tired more often. That is like the main symptom they have. So in a physical therapy rehabilitation setting, what you have to, what we use a lot is the Borg scale for transplant kids, so that they can refer to us when they're feeling extremely tired, and then we take a 5 minute, 10-minute breaks and keep on doing our physical therapy like nothing has happened. I don't know if that answered your question.
Yes, that was really good. Are there any other questions from people that are watching the presentation? Yeah, I'm not seeing anything come up on the chat line or the audio. You know, I was thinking one thing about what you were saying about the ratings of perceived exertion, the Borg scale. I had done a study where we were looking at women with breast cancer, and we did maximal VO2 tests before and after radiation treatment. And we went back in and looked at their ratings of perceived exertion during the testing. for only the women that actually achieve the requirements for a maximal test, which are, that the heart rate levels off and the VO2 either levels off or goes down. And we were finding that they were reporting a rating of perceived exertion about 2 numbers lower than what their VO2 max percentage was. I'm sorry, their VO2 was according to their VO2 max. And so I think the Borg scale is very good for cancer patients, but I think we still need to validate whether people are not reporting to us how hard they're actually working, and then we might have to move the number down a little bit for how, what they're reporting. So for example, if they're reporting that they're at about a 12, their VO2 max might actually be at a 14 out of 20, and that would be putting them in a whole different scale. So like the other test that you were talking about, it would be important for us to take a look at how accurate the ratings of perceived exertion is for this group of people.
Yeah. Yeah. What happens with children is that, for example, young children do not understand the Borg scale.
Right.
So they do not use it. And most of the time when the child is tired, he will sit. He will sit or tell us that he's tired or that he doesn't want to play anymore. But what we do have with bigger children, like 7 to 14-year-olds, is that they have had all this treatment done to them, and they have been in a hospital. So when they get to the physical therapy, they feel like they're okay, like the disease is gone and they can do whatever they want. So most of the times they do not want to tell us that they're tired, because being tired means that they are sick again.
Mm-hmm.
So we have that issue. We have that issue with a lot of children. What we do is that we say we are the ones that are tired and that need a break, so they will take a break with us.
Oh my!
But yeah, we have to. I think that's a lot of the experience that you have to see when the child is actually like lying to you regarding his stage. So most of the time we use us as an excuse so that the child does not feel like he's getting worse or that he cannot do something.
This is such an intricate area.
Yeah.
Do we have any other questions from people here? Yeah, I don't see any questions on the chat line. So do you have any final comments that you wanted to make, Pia?
I think this area is still feared by a lot of physical therapists. Don't have fear. The child probably won't die during physical therapy, so that's okay. Just be bold and get in this area. It's a beautiful area that not many want to participate in. We are lacking physical therapists. At least us in Chile, there are very few. We are actually 6 physical therapists for a population of 17 million of people. So feel free to ask any questions. Don't fear what you're doing, and just get involved in the area.
Thank you, thank you. I do have one final question based on what you're saying now. When I was thinking about your presentation, yesterday and this morning, I was wondering how you're doing such important work, and it's really rewarding. I did work in pediatrics in the school districts and in the hospitals a little bit when I was younger. And I felt good about it because I was able to use play to get the kids interested in participating in therapy. But when you get into a situation where you have children with these just overwhelming diseases and conditions, and the issue about them going into hospice and palliative care, how do you do you be nice to yourself? How do you take care of yourself so you can continue to approach this in a positive way? Do you think it takes a certain type of a physical therapist to be able to specialize in this area?
I think this area requires that, first of all, you have to understand that death is something that will happen to everybody. It is not something bad that will happen. And, well, for example, I try always to give my all to the children and their families. Even if sometimes giving their all does not match what you were taught in school. For example, I've had sessions with childs that are in palliative care where the whole 45 minutes I only held the child because he was feeling down. And that, even though they always tell you that you have to do something for them, just holding them is enough in that stage. Just talking to the mother when they cannot understand the pain their child is going through, or what is going on, or why, and I get this a lot, why God is doing this, but you always have to keep a positive mind that the child, I don't know, personally I think that the child came for a reason, and he's going for a reason. Maybe it's to teach us something, to teach the family something. But I personally like to, I don't consider them gone when they're dead. And actually, I use the experience they gave me, and I keep talking to the families after the child is gone, because, and I read this also in a study that the parents of children with cancer what feel most, even more than their child dying, is that the medical team abandons them after the child dies. So I always try to keep talking to them, and I invite them to go and see other sessions with our children so that they understand that even though their child is gone, I keep working for them.
Yeah, that's such a deep and beautiful respect that you provide the children as well as their families. Thank you for, that's such a critical, deep respect for life and the time that people are with. You know, I think that needs to be present, you know, not just in kids, but, you know, people who are, you know, facing these situations, you know, throughout the lifespan. So thank you so much. Philosophy and your beliefs and your personal strength in this area and your wisdom. So yes. So if there are no further questions, I think we will be closing the session. Nina Chegbo, who's our Educational Director for the World Congress for Physical Therapy for our oncology group, she's going to be sending you an International Scholar Award for your presentation today. And we want to thank you wholeheartedly for the information that you're sharing with us. Also, I am going to stop the recording, but I'd like you to stay on the line because I want to discuss some things with you in terms of the World Congress and moving forward, if that's okay. Do you have the time?
Yeah, I have the time.
Okay, great. All right. Well, thank you everyone who was here. I hope that you got a lot of great information from the session. And again, Pia left her email address if you have any future questions. So I'll turn off the recording and I'll bid everyone else adieu. So have a great week and take care. Bye-bye.